You're listening to the Assembly on Allergy, Immunology, and Inflammation podcast, brought to you by the American Thoracic Society.
Well, hi and welcome everyone to this episode of the ATS AII podcast. I'm Sara Assaf. I'm an assistant professor of pulmonary and critical care at the University of New Mexico, as well as the chair of the web committee of ATS AII. In today's episode, we're gonna try to dive deeply into the evolving landscape of COPD management. And to do that, I'm joined with a great lineup of experts. I would like to first introduce Dr. Klaus Rabi, who is a professor of medicine at the University of Kiel. He's a specialized in obstructive lung diseases and joining us from Germany. So thank you so much.
Thank you. Thanks for having me.
Next, I will introduce Dr. Butt. He's a professor of medicine and endowed professor of airway diseases, as well as the director for the Center of Lung Analytics and Image Research, the Pulmonary Rehab, and the Pulmonary Function and Exercise Physiology Lab at the University of Alabama. Thank you, Dr. Butt, for joining us.
Thank you for having me.
Dr. Nick Hanania is our next speaker. He's the director of Airway Clinical Research Center, as well as a professor of medicine at Baylor College of Medicine, and the PCCM chief at Bantab Hospital in Houston. Hi, Dr. Hanania.
Hi, Sarah. Thanks for having us.
Thank you. And Dr. Stephanie Christensen, she's joining us from UCSF. She's an associate professor in the Division of Pulmonary Critical Care, Allergy, and Sleep.
Hi, Dr. Thanks Christensen. For having me. Thank you.
Thank you all for joining us. So without further ado, we're gonna start with our first question. We know about the COPD being, heterogeneous disease, and traditionally we've known a lot about type 1 and type 3 inflammatory pathways, but now we're talking more about the type 2 mechanism. So I'd like to start by breaking down those endotypes and trying to see what is the specific role of type 2 inflammation in COPD.
So I can maybe start and then see what my colleagues say, but it's an exciting time for COPD because I remember 31 years ago when I started my clinical work, we thought about it as a one-size-fits-all. And we thought this is a disease that is characterized by airway obstruction. There's nothing we can do. Patients are going to die. They're going to smoke until they die. But now we have a new look. One is a treatable disease. Second, it's actually a heterogeneous disease, like you mentioned, Sarah. But not only that, it's not only heterogeneous with the presentation of these patients and the phenotypes, but we know that there are at least 3 mechanistic inflammatory pathways, like you mentioned. Type 1, type 3 are the most common, and that these are characterized by neutrophilic inflammation. And it's very hard to treat because they don't respond to anti-inflammatory, the one that we use at least. And then the type 2 is a new kid on the block, I would say. We're used to it in the asthma field. As you know, I wear both hats. But for many years, we did not think that COPD patients may have actually type 2 inflammation, driven by both the innate immune system and the adaptive immune system. Adaptive immune system may be related to allergen and other exposures, but the innate immune system may be related to pollutants and other exposures. And both drive very similar downstream signal through cytokines, epithelial cytokines first, but also the type 2 cytokines, that IL-4, IL-5, IL-13, driving eosinophilic recruitment to the airway, mucus hypersecretion, remodeling, airway twitchiness, and of course, the symptoms and exacerbation that is associated with it. So that's exciting. We have a new type of COPD that we can identify. Now, it's 30 to 40% of patients, but it's an important group of patients.
I think if I may add something, I think it's the right question. Sort of what has happened recently in this inflammatory science, if you want, around it. On the other hand, to add to this, clinically, this remains a very heterogeneous disease. And I think one of the reasons why we probably have been falling back behind other disciplines to develop a taste and a motivation for personalized treatment is because of that heterogeneity. So I think the secret lies a little bit in the problem about calling a disease as heterogeneous with one name, calling it COPD, while we all acknowledge, we all that are doctors and clinicians, that someone that has a severe emphysema with a high CO2 that is on a non-invasive ventilation surely is different from someone that has chronic bronchitis, flare-ups, inflammatory responses with a certain cellular endotype. So for us, what's so exciting is that we were a little at a loss clinically about the heterogeneity. Now translating this into inflammatory endotypes through drugs has helped, I think, all of us in the program to reset our vision of where the segmentation and the order about this disease probably better lies to manage the disease better. That's for me something that has happened over the last years, which I find extremely rewarding for patient care.
And I think one of the other, as you're kind of getting, we're really still actually learning a lot about these endotypes. It's not necessarily the same thing as asthma. These are older patients. They may have had a lot of deconditioning over a long period of time. They all have, by definition, have fixed defects. And so we're still learning about, okay, well, are there some patients who have both type 2 and type 1, type 3 inflammation kind of at the same time? And how do those people respond to our therapies? How, versus somebody who's really a much more very type 2 or very type 1 and type 3. And I think we're still actually learning about some of this heterogeneity so that we'll be even able, hopefully over time, as we learn more and see more of the trial data come out, be able to kind of understand better who's really going to be a responder, who's really not going to be a responder, how do we treat these patients better, and hopefully as we learn more from some of the other biologics that are being studied, alarmin-based, or even some of the drugs that are kind of in earlier trial stages, I'm hopeful that we'll actually see like a lot more about what that heterogeneity really looks like. So I think it's a very exciting time, and maybe the fact that some of the drug companies are so interested in this now means that we're actually seeing a lot of real-time kind of human data come out to really understand this.
I agree. I think we've talked about precision medicine for a long time, and then most of our efforts have mostly been structural phenotyping, clinical phenotyping, with not really much to do to modify the course. And we've been throwing the same medicines at all the people, hoping for similar responses, obviously without getting the same response. So I think the whole movement toward endotype, I think it's really exciting. And I think Stephanie brought up a good point that these are still not clean endotypes. I think most patients have a mix of type 1, 3, and then type 2 inflammations. I think we should keep that in mind when we treat our patients and look for the responses that we're expecting, which sometimes we get and sometimes we don't.
Well, the interesting notion is, I think we all share this enthusiasm about it, that this field is moving after a decades of stallment and a lack of drug development. But I think what's very interesting to me is that the main driver is the intervention. So it's all very well that we explain the immunology now a lot better, and we learn from this. But to be honest, one of the accelerator this has been in an intervention that is targeting a certain step, and you say, hey ho, your clinical parameters improve to a meaningful extent, and then you think backwards, which I think is very important. So when we talk about maybe biomarkers later, these 300 cells per microliter were in documents that were talking about the use of inhaled steroids. I mean, let's face it. I mean, there was the thinking that there is something in this inflammatory response, but coming up with something which is targeting, personalized, as Surya was saying, gave us better clarity and drove us into the different areas that we drove, and initiated more developments in those people that make these drugs. And it's a self-accelerating system, which that makes it so exciting at present.
I know when I was in the medical school, we learned about blue bloaters, pink puffers, right? And now there's this more endotyping, this more phenotyping, pretty much an exciting, framework. So when we're seeing our patients in clinic, we see a lot of COPDers who are optimized on their inhaler therapy, but they're still having quite a bit of symptom burden. They're still frequently exacerbating. So how can we use this endotyping and phenotyping to reshape the care that we're providing to our COPD patients? And can we talk more about precision medicine and this personalized approach that we all kind of discussed?
Sure. I think one of the things that we shouldn't forget before we move to precision medicine also is there are several interventions that pretty much work for most people. When we say optimized, we want to make sure that they're truly optimized with relatively inexpensive, safe, easy to use medications. For example, we want to make sure they've quit smoking if smoking is a risk factor for them and is an ongoing thing. We want to make sure they've taken their immunizations. They do decrease exacerbation frequency. Hopefully they've gone to pulmonary rehab, which also decreases exacerbation frequency. They're using their inhalers on time and are compliant with them. If they need social assistance, I think we should make sure that we provide that. And then also make sure that they're using their inhalers correctly. So a lot of people make significant critical errors in how they're using their inhalers and may not be getting the medications. Once all this is sorted out, I think we need to then phenotype them and see if they are frequent exacerbators, because there's always a risk benefit that you have to evaluate before you start new treatments. And there, I think, is the commonly accepted thresholds is 2 moderate exacerbations and 1 exacerbation in the previous year. But I think the field is also slowly moving toward every single exacerbation being important and not necessarily having to wait for 2 or 3 exacerbations before escalating treatment.
I agree. One of the things we missed on this disease is the patient, who is really the focus of attention. We sometimes, as physicians and clinicians, we just are there to prescribe medicines, but we don't know the receiving end. What do they expect? Actually, I was reading an abstract at ATS last year. I don't think it's a paper yet, but there was a survey on both new patients and existing patients. And what are the expectations of these patients? Well, majority of patients, actually more than a third of these patients, along all the questions, wanted to get better, get active, not have emergency room visits or hospital admission, and go back to work. So I think the leveling the expectation of care is part of a precision medicine approach. It's not just about new drugs and new biologics, but getting shared decision making in the equation is very, very important.
And I think some of that comes to the what is an exacerbation? What does that mean for your health? Right? Like that exacerbations can be just as bad as things like heart attacks or other big comorbid problems and lead to increased mortality, increased symptom burden, rehospitalizations, all of these things that we really want for patients to not be experiencing. And I think there's, sometimes they reset their levels, reset their expectations because they don't realize. They're like, okay, well, I got some steroids and I feel better. But I'm like, but do you feel back to your baseline? It's like, no, I haven't felt back to my baseline for years. And they kind of keep having this kind of low and continued spiral and trying to understand, hey, we should be preventing these, which means, yeah, you should be taking your inhalers daily. We really do need to work on that. You should be trying pulmonary rehab. And if we can get you, and if we've kind of exhausted those things, and we can get you on a drug that could be beneficial above and beyond these, which a lot of patients need, like the triple therapy studies, I think almost 50% of patients were still exacerbating, despite those are the patients that are going to do the best on these therapies, right? Like they are being watched like hawks. So the fact that you're still having these exacerbations, these symptoms, this kind of continued slow decline, really getting patients on board that, hey, we can work on this to try to prevent you from feeling that worse over time. Like think of how you felt 2 years ago, 3 years ago, versus how you feel now. Can we kind of, prevent that forward progression? And so I think some of it is, for me, it's like really working on that level setting and doing a lot of that teaching to patients and actually to other providers, because I think a lot of us, I think there's a lot of providers that don't realize how impactful these things are.
Yeah, but I guess I fully agree with this. But if I may pick up what Nick was saying is this area of what is the patient expectation, and I think again that brings us to the heterogeneity of this disease because their expectations will be very different. I think we've been focusing very much for very good reasons on exacerbations. Part of this is because clinical trials and the legislation around registering drugs is around exacerbations. But the majority of patients that we see and primary care is seeing, and this is again heterogeneity, the caregivers. The patients that I think we all see are at an end of the spectrum that have seen other doctors. They have a long career of the disease. They may have terminal illness with high capacity. They have a sort of ventilator support. They are severely dyspnoic, and they may or they may not exacerbate. So I think what we're all saying is that we need, with all the personalized therapy, you're talking, I think, in this panel with doctors. And I think none of us forgets this, that we care for individuals with all their breadth. And I think we all are very careful in understanding that novel therapies such as biologics for COPD are for a segment of this huge population worldwide. For some segments, it works miraculously well, but there is a huge group of individuals where simply there are clinical characteristics where we have to say we're not there yet. And I think that is a very important point to make in terms of expectations as well. And when we go to the media and we write a nice paper and we're all very proud of it, and then we go in the local media and we say this is a new drug. I mean, my secretary hates me because then you get these people calling in with all sorts of diseases, but they think, I've heard about this new miracle drug, can I have it? And you have to say in many, many cases, no, we can't, because you're not falling into these categories. And heterogeneity also means you have to disappoint individuals to a certain extent of advanced diseases. And listen, unfortunately, you don't fall into this fortunate gap. And I think that's something we all need to get across, that we manage expectations from patients, but also from other colleagues and caregivers in the right and proper way. And I think that's what Nick was saying just to an extent, and I very much agree with this.
Yeah, well said.
And as Nick was mentioning, he talked about some inflammatory markers and the cascade for T2 inflammation, interleukin-5, interleukin-13, interleukin-4. Can we detail more the roles of those cytokines, and what do we know so far from the studies and the clinical trials about the T2 inflammatory pathway and targeted therapies? We can also mention as well alarmins and what we know so far from the studies. Dr. Hanania, would you mind starting with breaking down the role of cytokines?
Obviously, cytokines are important, but these type 2 cytokines are very important. But then let's not forget there are also epithelial cytokines right there that are the master planners. They work in propagating both type 2 and type 1, type 3 inflammation. But when it comes to type 2 inflammation, since this is the focus of this webinar, we're talking about IL-13, IL-5, and IL-4, the main ones. IL-5 is really very important in eosinophilic recruitment, keeping eosinophils happy, maturing them, preventing them from dying. It has other functions. It has functions with remodeling and other things. So it's not just eosinophils. IL-4 is a very important cytokine because it does work in iso switch of the B cell and IgE production. So in allergic COPD, and there is such a group, by the way, we always think allergic is asthma. No, there are allergic COPD, and we have, Stefan and I are involved in clinical trial now looking at COPD patients with allergic sensitization. So IL-4 is very important in both eosinophilic recruitment, but IgE production. IL-13 is a pleiotropic cytokine. It's a jack of all trade, I call it, because it's actually a very important one to block because it can increase mucus hypersecretion. It can contribute to airway remodeling. It certainly can affect eosinophilic recruitment, but also airway smooth muscle hypertrophy. And so I think all three orchestrate together the type 2 inflammation. Each one has a specific function, and certainly blocking one or the other or both may have a beneficial effect downstream. In selected individuals, I agree with Klaus and everybody else that not everyone with COPD would be candidate for type 2 biologic. And it's estimated that maybe up 5 to 8% of the severe COPD population may, or the population of COPD may be candidate for the ones we have at least right now. So it's a small portion, but a very important portion.
And I can speak a little bit to the data that drives who might be candidates. So mostly, we have to follow clinical trial data for best evidence-based practice with a little bit of personalization based on who we're seeing and putting multiple pieces of information together. But right now, the approved drugs, dupilumab and mepolizumab, are both targeting type 2 inflammation, which is more modifiable than type 1, type 3 as where we stand now. So mostly they're targeted to people with frequent exacerbations, often defined as 2 moderate or 1 severe in the previous year, and with optimal therapy, ideally triple therapy, as long as they can tolerate all 3 components. And then to have type 2, evidence of type 2 inflammation. And some people call it eosinophilic COPD, some people call it COPD with type 2 inflammation. So the general cutoff is around 300 eosinophils per microliter, but obviously it's on a continuum. So in the original METRIX and METREO studies looking at mepolizumab, which had mixed results, the inclusion criterion was eosinophils of 150 at screening or 300 historically. And they found that the METRIX study, which included both, was stratified by high and low eosinophils. It was overall not a successful study, but in the pre-specified analysis, when they looked at half the population with high type 2 inflammation, there was an 18% reduction in exacerbation frequency. And then in the METREO study, again, it fell short. It was also an 18 to 20% reduction, but the p-value just fell short of significance. And then more recently, they designed the MATINEE study where they flipped the eosinophil thresholds a little bit. So they had to include people with 300 eosinophils at screening and 150 historically, and they found a 21% reduction in exacerbation frequency. And then we know of the dupilumab studies, BOREAS and NOTUS, which had almost identical results. There they used an eosinophil threshold of 300 cells per microliter. And in BOREAS, there was a 30% reduction in exacerbation frequency, and in NOTUS, there was a 34% reduction in exacerbation frequency. So I think these results are quite impressive for exacerbations, but they also have significant impact on other components. So in the BOREAS and NOTUS studies, there was also a almost 83 ml improvement in FEV1, which was quite quick, within about 2 weeks of initiation of treatment compared to placebo. And then there was also a significant improvement in quality of life and daily symptom burden. So I think these are the data points that guide us as to which drug to use. And these are the 2 approved therapies for type 2 inflammation right now.
And what biomarkers are available for us to, better pinpoint what would be the best treatment for the best patient? I know we're still having a long path in terms of biomarkers for COPD, but what do we know so far about laboratory biomarkers, clinical features, or other strategies that clinicians can use to, better align the targeted therapy with the right patient?
Well, I think it's mentioned, but the funny thing is, before we get to the things that we measure, all the factors, all the type 2 cytokines like IL-4, IL-13, IL-5 are not the biomarkers that we use, which is interesting in itself. So we use, in fact, the mirror of the events that these cytokines orchestrate. I think that's what I would look at it. So we look a bit of the backside mirror, what is orchestrating this. So basically, we look at the effects of what we presume is the resultant of the cytokine being present without knowing in what concentration, what site it is in fact present. Sounds complicated, but I think for the listeners, that's an important thing to know. Since these cytokines have some form of overlap and redundancy, you will have to conclude from the biomarkers that you have that 1, 2, or the mixture of them is orchestrating this, but still that level of precision to know exactly which one it is, in all honesty, we're still missing. So we have, if you want, we have clinical biomarkers, which is a biomarker in itself. To be symptomatic, have a poor lung function, and then be exacerbating, I would call it that could be a clinical biomarker in a true sense. Then we have imaging biomarkers. We know about the mucus plugging story. We know about sort of the airway disease. So imaging provides also biomarkers, and I think they always get a little bit out of sight, but we as doctors will use them. Sort of most and importantly, that's what we do. And then you have the eosinophils, which miraculously seem to be working in different diseases at a cut of 300 microliters per ml, which I still am surprised how constant that finding is, indicating a risk for instability. So eosinophilia is probably the most prominent and most reliable marker that we have so far. You have FeNO, which for asthma is clear. For COPD is less clear. That's evolving, and the trials would indicate that there's also a signal there that may and will be able to contribute. And then you have another type 2 marker, which is IgE, which is interesting because classically it's been related to allergic disease, sensitization, what have you. But there's no doubt in my mind, and since Ben Burroughs data almost 100 years ago, if you smoke and you get older, you may have increased IgE level. So there are other factors that are not classically related to allergic sensitization that would increase this biomarker as well. So that's the three that we have. But I think for most sense and purposes from the clinical trials, and I'm curious to see what my US colleagues would say, eosinophils are at present the joker, the most prominent joker that people hold in their hands. That's the best card that I think you seem to be having at present. That's at least my impression. Over to you guys.
Yeah, I think eosinophils certainly are important, but again, there are lots of issues with that. None of the biomarkers we have right now are ideal. One is eosinophils can fluctuate and certainly can. Historic eosinophils are actually as important. In fact, there was a paper from the East London group looking at eosinophil over time. There's some fluctuation. So I look in my patients in the clinic. I look at. I have access to their Epic, and I can do the EMR. I can look backwards and look at eosinophils, not just one time. And you can see they fluctuate. Yes, 300 has been used in clinical trial as cutoff, but actually there are some data from the clinical trials showing that actually the response to biologic may be seen even with lower than 300. The jury is still out there. We need to decide, but then there's some emerging data from the asthma literature, and hopefully we'll see it more in COPD, that composite biomarkers may be actually a better way to look at these patients. In asthma, we looked at EOS and FeNO together, and they were actually, when you merge both of them together, they are more meaningful prognostically, but also predictive as predictive biomarkers. I have to say that the role of FeNO in COPD is still up there. Surya, Stephanie, and Klaus and I were investigators on the large trials with Boreas and Notice, and we did look at FeNO, a cutoff of 20 parts per billion. Why we chose 20, not 25 in asthma, we don't know. But in general, FeNO was a predictive biomarker if it was high. But in smokers, and smoke exposure can lower FeNO. It may not be very helpful, but also FeNO has fluctuation from day to day. And so one has to be careful that one reading may not be enough. I personally, in the clinic, I'm not measuring FeNO in all COPD patients, but I do measure blood eosinophils. Maybe I'm wrong, maybe I should be, but I think we need to look more about FeNO stability and the utility in COPD. There's some data to show that it is a prognostic biomarker as well.
Yeah, I think the trial data isn't there yet for FeNO, but I think it's really provocative what we've seen, and we don't know if current smoking just means, hey, you've actually got a lower threshold and that it's still useful, but you have to be looking at lower levels to say, is what's actually high in a current smoker, or is it just not useful at all? So I think we just don't know that answer very well yet. Mm-hmm. But I think that the data there is just not. We don't have so I agree with you. I don't check FeNO in my COPD patients either, and I don't think the data from the trials support it yet to be looking at that. I think we've got some data that really suggests, hey, we should be studying this more, right? And I think we got a lot of data on blood eosinophils, but I think there's also looking at what's closer to the airway and what's, especially when we're talking about mucosal immunology for a lot of these patients, like what's happening at the level of the airway, like looking at, hopefully over time, we'll be able to develop other biomarkers that, including, there's FeNO that's we're measuring from the airways, but there's certainly, we see sputum eosinophils tend to be a little bit more predictive than blood of having type 2 inflammation in the airways. So I'm hopeful that we'll actually start seeing better biomarkers over time of what's happening
Well, we
there.
know that FeNO is a good reflector of
Yeah.
IL-13 activity.
Yeah.
So I think it may be, as the market gets crowded with more biologic, hopefully in COPD, it may be a helpful tool that would, if somebody is failing one biologic, a high FeNO may suggest choice, like we do in asthma right now.
Right.
Certainly IL-13 is the one that is linked to FeNO production. IL-5 definitely is linked. All of them are linked to eosinophils, but IL-5 particularly. So I think they may be helpful and also it's a pharmacodynamic biomarker actually. Now that doesn't usually correlate with clinical response, but if I see FeNO come down from 40 to like 10, I feel comfortable that I'm targeting the area of inflammation that I want to with a certain treatment. And you see that with certain biologics and steroids, of course.
I think I'm very much with Steffi. I believe what I take from the data, it's enough data there. It's worth studying, and you would want to understand this. One drawback theoretically that I see is that we haven't talked about alarmins a lot yet. Maybe we will cover a little bit of this. Is that it seems not so easy to actually find really the biology of alarmins that are epithelial derived, as is FeNO, to actually play a role in the modification of that disease process. And I would have hoped that anti-alarmin therapies would teach us a little bit more about biology of the epithelium itself, including FeNO, to actually understand where this is going. And I think in all respect, I think the Dupi data have been so far more convincing in 2 clinical trials than the anti-alarmin data that we've seen so far. There's clearly efficacy, but it's not that clear cut to say, listen, hey ho, that is, we know which patients there are, we know where the benefit, and the signal has not been as crystal clear as we've seen with an alpha IL-13 antibody. And that is stimulus enough to go on to understand that, but I think there's something that we don't know yet, and I think that's what Stephanie has been saying, and I would very much agree.
Can I also just one quick put a plug in for what Klaus was also saying about clinical biomarkers, because I do think that's important here on like what we should use and what we shouldn't use. Like I think, chronic bronchitis was a eligibility criteria, right? Inclusion criteria for the Boreas and Notice trials. It actually wasn't for MATINEE, so the most recent mepolizumab trial, but they did see that actually the patients who had investigator identified chronic bronchitis actually did have that group had some of the most benefit from the drug. So it does look like, hey, actually finding a symptomatic group may be particularly helpful. And that's who we know that it works in. That said, that drug did work over everybody, including the people without chronic bronchitis. But if we're trying to figure out who might have the most benefit. But something else that we noticed is that, hey, as long as you had met eligibility, even if you have emphysema, which usually we wouldn't think of as somebody who would benefit from one of these drugs. Well, if you also have exacerbations and chronic bronchitis, even if you do have emphysema, that some of those patients still do seem to actually be to show benefit. Now, they may not, we may have level setting there, it's not like they're going to get back to completely, they're not going to feel 100% like maybe an asthma patient that has a really amazing benefit from a biologic, but they can have benefit. So I think that those are also important parts, that some of those clinical biomarkers that maybe we, some of them sort of make sense, but some of them, hey, we actually had to kind of think about like, hey, maybe I can use this in a emphysema patient if you still have kind of all the other, you meet all these other boundaries for us. So I think that's important too.
I think it's important because before Surya comes in, I just have to get back to this because I think I'm entitled I may say this because I'm a co-author of this data. I think there's a caveat still. The statement that people have emphysema, and I'm saying this as an author, and I say this with full responsibility, and I know that we share the same view, was not the perfect way to define or to rule out
That's
what level of
absolutely true.
diffusion capacity impairment. So I would believe that for all our listeners and for all the discussion, I'd say an emphysematous lung is still the goal for me, amongst others, to reach, because it seems that this is something where we really need more data. They may have other types of inflammation in them once the tissue has vanished, once the vasculature and the airways and the smaller ones probably are gone. So I'm a little uncertain about the statement that emphysema is still qualifying for it, but I think we all agree that's one of the holy grails, if I may say, where we need interventions on a pharmacological way. We would like to see efficacy on, if you allow me to
Yes,
put
no, and
this in
I
perspective.
am not, I'm certainly not saying that it's the emphysema that's being targeted, but I am saying that, hey, even if you have an emphysema patient, I'm
Yes.
still checking blood eosinophils. I'm still thinking about exacerbations, chronic
Yes,
bronchitis,
agree.
other symptoms that may not be unrelated or a different set of phenotype, if you will, or endotype than what is happening with that emphysema, and that I still should be kind of thinking about whether or not you might benefit. And some of the nice things about these drugs is like you don't have to, if it isn't working for you and you found that out over time and you're not having reductions in exacerbations or symptoms, you can stop the drug. You're not going to have, so that
I
so
have,
that those are
I have a bit of a different take in a way from emphysema. I agree with you. The clinical presentation of these patients was mainly on self-reported. But let's not forget that emphysema patients have significant small airway disease. This has been shown many, many years ago. You all are familiar with Jim Hawk papers, and now we have all these CT scans showing that they may have emphysema, but they still have some small airway plugging and mucus plugging. And I think the reason it may work in that population is not just reversing emphysema, which we don't have an evidence for, but it may affect the small airway function. And that's why what's interesting is, as pulmonologists, we don't measure airway function in most of these patients. We measure large airway function like medium size FEV1, but we forget to measure the small airway function. And I know that there's lots of push now, including ATS, to actually look at doing impedance oscillometry, looking at small airway function, and not just concentrating on the FEV1, which we know that right now it's the holy grail for diagnosis of COPD for now, but things may change. But I think small airway function is what probably these biologics, because they are given systematically, they don't have to be inhaled, so they do reach the areas where we want them. But there's some data on the cytokines, since I was asked to talk about cytokines, that, I think at least IL-13, mostly in vitro data, that it can contribute to destruction in the terminal lung. And so hypothetically, blocking it may improve, but we don't have good CT evidence that we can reverse emphysema with these agents at this point.
Is it also, Dr. Hanania, with maybe remodeling of the small airways, like hastening it or helping with that? Not sure if there are any data or any radiological or mucus plugging data or anything that we know so far.
There is a study ongoing looking at dupilumab and on small airway function and also on mucus plugging, just like we did in asthma. The asthma study was published, the Vestige study. It's clearly looked at small airway function, but also looked at mucus plugging. The good news is we have protocols now. We can actually count mucus plugs. And actually, Dr. Bat has been very on the forefront of this type of imaging studies. I agree with Klaus. Imaging biomarker in these in deciphering this is very, very important. And I think so we can count mucus plugs. Radiologists now, there are protocols. We're not doing it in real life yet, but I think we can measure airway wall thickness. We can measure the any gas trapping and density of the lung to measure exactly. So we don't need to do biopsies on these patients to know that there is an effect. So I think you're going to see that's one of the big unmet need with biologics in COPD. We need long-term data. We need more mechanistic studies to understand why they feel better. And can we actually reverse the disease? That would be a miracle if we can. And if we can, then maybe we can justify using these early in the disease process. Right now, we wait until the horse is out of the barn and then try to get them. It may be too late. They have burnt out lungs. Maybe if we can show that there may be some delay in the disease progression, then we can justify using these biologics early in COPD, for example.
Yeah, I think this is a really exciting area of research right now. So there's plenty of evidence from asthma that both dupilumab and tezepelumab decrease mucus plugs, and dupilumab's also been shown to decrease airway wall thickening. There's also improvement in ventilation defects on MRI. The only study we have so far in COPD is a phase 2 study with the tozorokimab study with Frontier 4, where they found a reduction in mucus plugs. And it was a numerical reduction, but we have to keep in mind that these subjects weren't enriched for people with high level of mucus plugs. So you could assume that if you had a high level of mucus plugs, maybe they would be more effective. That's possible. But I think there's a lot of studies upcoming looking at these kind of imaging biomarkers. And I think the promise is, you can target a small number of subjects and try to get a meaningful effect and potentially signals for disease modification, which is, I think, where we need to go, not just focus on exacerbations.
So to wrap it up, I think we're all very excited, right, with all of the new knowledge that we have, but still quite a bit of unmet needs, as Nick mentioned. I want to just hear from each one of you. What are, the future research needs with patient selection, with biomarkers, surrogate markers, and a lot of questions also that could be extrapolated from asthma and targeted therapies to COPD patients. Like Stephanie mentioned, if it's not working as a targeted therapy, we can stop it. How do we know when to stop, when to switch? Can patients maybe eventually de-escalate their controller inhaler medication, things like that in general?
I think one of the research needs is not only biomarkers and drug development. I think what has happened, and that's what my, let's say, emotional side of this is, where I believe we are witnessing something extremely important. You mentioned it is early disease. And the question is, if you are prepared to actually interfere with an inflammatory response resulting in different end products, vascular, alveolar, airway, if you interfere earlier, then that may treat a very different biology. You have made a much better opportunity to interfere. But most importantly, to me as a clinician, it means that our whole classification of diseases with these interventions will come under pressure, because we call a disease asthma or COPD by gestalt recognition. Old, have smoked, looks like emphysema is COPD. Younger, sensitized, history, maybe more asthma. What will come under pressure is if we really understand, like the oncologists, that doesn't matter whether it's squamous adeno or cribriform, whatever. It's P53, ALK translocation, EGFR positive negative. As a biomarker, there must be immunological endotyping that would say, listen, whatever your age, the inflammation that you have and the symptoms that you present are in principle a target for an intervention X, Y, and Z. It doesn't matter what I call it. It's a mechanism that I want to address. And that is something that is really changing, I believe, how we will address in the next years and decades obstructive lung disease, because we don't know where the limits of this are. And this debate of this is asthma and I know it. No, you don't. The question is, what is the mechanism? What is the immunology? What is the biology? And what is the target that you can interfere with? This is, to me, the most exciting part of a completely new thinking around these disease entities.
So, Sara, to answer your question, I mentioned disease progression. That's a very important aspect, because right now we are talking about a term called disease stability. There was a nice review recently. Surya is one of the authors. I don't know if Klaus was or Stephanie. in Blue Journal on disease stability. We don't use remission yet in COPD, we do in asthma, but disease stability may include more than one thing: exacerbation, flattening, symptom improvement, lung function decline. That would be a very important thing to look. We need long-term studies, larger, and maybe even on less sick patients who are not burnt out already. I think the effect of these biologics safety-wise on long-term is very important. We're dealing with a comorbid population, or multimorbid, I would say, population, effect on cardiovascular system, because that's something that hasn't been looked at systematically with these biologics. Are we targeting inflammation in the lung? Can we affect cardiovascular comorbidities? We know that there is a huge link between exacerbation and heart attacks, for example. I think these are important issues. And of course, mechanistic studies like CT scans, like we mentioned, looking at what happens to mucus plugging, small airway function, are very important to enrich our knowledge, but to reassure us that these drugs are different than other symptomatic inhalers that we have. Not to undermine those, but so far we haven't really done too much to move the needle for COPD. We give them symptom relief, exercise improvement, but we can't modify the disease progression.
I agree with Nick. I think the thing that excites me the most is the potential, not proven yet, of these biologics to potentially modify disease. I think we know that most COPD tends to progress, not all, but most tend to progress, some faster than others. And I think with these new imaging advances, I think we have potential surrogates to study disease progression faster and identify people who might be targets for altering that progression. And then when it comes to progression, obviously you have to look at short-term progression, long-term progression, same thing with stability, short-term stability and long-term stability. How long to give these biologics for is something you asked earlier. I don't think we know the answer to that. Right now, there's not long-term studies. There's no reason to suspect why we shouldn't be giving this longer term. The safety profile is quite good, but we know from asthma data that there can be almost like breakthrough lack of treatment effect. So I think we do need to keep a close watch on patients to see if we need to switch therapy. At this point, I think we don't have data for stopping ICS, for example, or withdrawing ICS. We do have to remember, unlike in asthma, most COPD have some element of neutrophilic inflammation going on. So I would be very hesitant to stop ICS if they're doing well on triple therapy and on biologic without seeing the data that it's safe to do so. For now, I think I would probably just continue.
I will quadruple down on the disease modification piece. I think we still don't really know how, let's say if we wanted to look at early disease, so before somebody got to kind of whatever their end stage is, somebody at 70 years old who's got mild disease, are they going to continue? They're 70 now. Are they going to continue to progress? Or are they just going to stay like that? Versus like a 40 or 50-year-old who, may be at that stage where they're going to actually get, be more likely to progress over time. But we don't know who those patients are to put into a clinical trial yet. Like who would I put into a trial? Because am I going to have a trial that's like 10,000 patients? No, that isn't reasonable. So I think we're still kind of working on some of those questions. Like, we've got PRISM, so our preserved ratio, impaired function, that group. But we don't really have kind of an understanding of like, what are our biomarkers what are our markers for who's a progressor that you might put into these trials. So I think that's an important piece. And I do think, as the additional data comes out on, let's say, the alarmin therapies, where we do think there might actually be, it might be a little context dependent, where some of those alarmins, even though we know they work with type 2 inflammation, they may work, in a smoker who's got different types of inflammation. They may work in a different way where they're really impacting type 1 or type 3 inflammation. And are we going to learn more from those drugs about, could we potentially interfere on those pathways, or other drugs that are now going to be in development, because we've seen some, we've seen some success, and now we're kind of thinking in this inflammatory immune paradigm of, hey, let's try to, this precision medicine immune paradigm, like, can we try to target this other group of patients, the majority of patients who don't have, or where type 2 inflammation, and targeting their type 2 inflammation isn't going to make isn't going to move the needle enough. So I think that's a very exciting place that I think we're definitely at, and I think we've got a lot of people excited about it, a lot of companies excited about it, and hopefully a lot of our researchers excited about it. So yeah, I think that would be my
I think
next step.
identifying a high-risk population, like Stephanie mentioned, we don't have a clue. We're trying to do that in asthma, by the way, but how do you define high-risk population of rapid decliner or rapid progression of the disease? We don't have good biomarkers to identify these. Once we do, then we can do clinical trials on these patients early. We talk about pre-COPD, but there are at least 3 buckets that constitute pre-COPD. Which one should we study? Is it the one that has CT changes? Is it the one that have symptoms? Is it the one that have physiologic changes like DLCO being low or gas trapping? And we have no idea. I think we need to put our heads together and come up with some kind of a definition.
And would it be one that's and has the immune response, or something like that?
Biomarkers.
I guess, Sara, you realize, I mean, we could talk about this for 12 hours at that one, and we would still not get tired. But I think what I find nice at this point of the discussion is that we have a closing loop, and this is again to the biomarker part. So we all say early intervention probably makes a lot of sense. If you modify something, don't do it in something that hasn't left the barn, because it's there's more plasticity, and you have an unknown sort of outcome. But then the biomarker question gets a completely new issue. This is not a disease severity drug response biomarker. Now you're looking for risk biomarkers. And the risk biomarkers could be something extremely different. You don't know in a given individual, sort of, with an FEV1 of X at the age of 35 that has smoked 10 pack years, what the outcome would be. So genetic, early life events, infectious, immunology. So the whole area about risk stratification led by biomarkers, clinical, imaging, genetic, immunological, cellular, that is a whole new area that people need to get into. I mean, all the researchers that are on that call, all young people, if you look for an area that is uncharted, it is one of those big things wherever you are, to look at risk stratification of chronic diseases, including the multimorbidities in their pattern. And that is uncharted territory, which is extremely good fun to go to.
That's awesome. That was really a great conversation. I want to thank you all. Dr. Bud, Dr. Hanania, Dr. Christensen, Dr. Rabi, we're closing with you because you're on an international time zone and you're still able to join us. So thank you so much. We will close up in the next minute. Any closing remarks before that?
Thank you, Sara, for hosting us. It's been a pleasure.
Yes, it has been my pleasure, and I congratulate explicitly ATS for doing this, to having this from the assemblies, from younger individuals, Sara, if I may be so free to say that, to convene people like us that sort of, come from different areas. Congratulations for doing this. It's very educational. And I really hope that our listeners took something from it, got inspired, and got entertained to some extent. Thank you for having me.
Thank you so much. Thank you so much. I very much appreciate your time. We're going to also thank our listeners, and we'll be seeing them in a different ATS AII episode. Thank you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.